As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com. Welcome to Beyond the Stethoscope, Vital Conversations with SHP. We're busy gearing up for Season 3.
In the meantime, enjoy this greatest hit episode from our archives.
We hope you enjoy it. We look forward to you joining us on October 11th as we kick off Season 3.
Welcome to Beyond the Stethoscope, Vital Conversations with SHP. This is Aaron Higgins. On today's podcast, Jason Crosby and I provide a quick overview of the PFS Final Rule, and we tease our upcoming Quality Payment Program webinar. Then Jason talks with Joe Ebberwein. Joe is the co-founder and CFO of Corstrata, a technology-enabled care management solution focused on improving outcomes for wound and ostomy patients. We gain data-oriented insight into this often neglected area of care, and how Corstrata is working on solving this care gap. They also discuss how virtual care and telehealth are viable solutions for any provider to utilize. Are you ready for this vital conversation? Let's get started. Hey, good morning, Jason.
Morning, Aaron. How are you?
Doing pretty good. How about you?
Excellent. Doing well. Thank you.
I think we have some headlines today, don't we?
Oh, we've got some very big, timely headlines, I think, today.
On October 31st, CMS dropped their annual final rule update for the Medicare physician fee schedule and other things. So we came across a great article by Beckers that was published almost the following day, which give 15 highlights from the final rule. Now, the final rule is something like 3,300 pages long, and I don't think anybody has really had the time to read through and digest it all. And we only have 5 minutes here to talk through this. So I'm going to try to take this away, Jason. So really, the conversion factor that calculates the physician reimbursement, that's going to decline by $1.55 to $33.06 next year. That's an almost 4.5% decrease. This accounts for the increase of 3% that expires at the end of 2022. And because of this, this is required by the Protecting Medicare and American Farmers from Sequester Cuts Act, which is, a fancy way of saying the sequestration rule.
Definitely the headliner point every ruling comes out is that conversion factor. It's a good point there. I also noticed in that same light, Aaron, something we constantly talk about is telehealth, right? Obviously, during with the public health emergency through the pandemic, that's been a concern. So here, what CMS has done is extended those services through 2023. So I'm sure more to come on extending beyond that, but that's an important point given how popular telehealth became. Another item that's interesting that's reflected here is on the ACO front. And so obviously recruitment into ACOs, making it a little bit more palatable for providers to venture in ACOs without shared risk being so quick, is a one-time payment, upfront payment for those that are considered on the low revenue side of $250,000 in quarterly payments for the first 2 years of that 5-year period for those that are familiar with that timeline. And that's just basically a help get up and going phase, which the ACOs will have to recoup when they start making money. So an important point there on the ACO front.
Pivoting from ACOs, we have the Outpatient Prospective Payment System, or OPPS, as I think most of us are familiar with calling it. So they're increasing, which is kind of a surprise, the outpatient payment rate for hospitals, as long as you meet the applicable quality reporting requirements. That's a 3.8% increase to payments. So that's important if you're a hospital who's listening to this podcast. check to see if you're reporting your quality requirements properly. And in line with the 2019 OPPS final rule, which finalized a proposal to apply productivity adjusted hospital market basket update to the ASC payment rates, they're going to continue to increase pay rates by also 3.8% to ASCs that meet the same quality reporting requirements.
Really important point there on the ASC front. Glad to see that. One item that became really popular last several months is regarding the rural emergency hospitals portion, right? And so a lot of folks trying to help the rural provider setting, given all the closures that have occurred. And so this became a little bit more insightful post January 1. So it tries to define what REH services include, which is helpful, and that is all covered outpatient department services when provided by this particular designation. And on the reimbursement side, which is an important point, they will be paid at a rate equal to the OPPS payment rate, which is the equivalent of, which should be increased by 5%, right? So beneficiaries won't be charged the co-insurance on that additional 5% payment either. And so a little bit of clarity there on the reimbursement payment front on the REH designation. In 2023, those rural emergency hospitals will receive a monthly facility payment that will increase in subsequent years as well by a certain market basket percentage rate. Very important point. Clarifying the reimbursement vagueness that we've had this year.
Yeah, those rural emergency hospitals are definitely hurting for some more payments. So I think this will help them significantly. And finally, in the Becker's article, they go into home health perspective system rule. And I got to be honest, Jason, it's kind of some muddled confusion here with this Becker's article. I think this is going to take a deeper dive to really fully understand. If you are a practice or a healthcare system that's involved in home health, you need to be aware there are some changes happening to home health payments. They are trying to streamline, they're fixing some gaps, they're stemming some bleeding in terms of overpayments that have occurred. So there's a lot to unpack. We just don't have time for that.
You know, Aaron, a big point missing from here. What did you notice is missing from this review?
Oh, definitely. It's QPP, the quality payment program, known as MIPS in some circles or APMs and others. That's a whole lot. Speaking of things to unpack, that's a whole lot to unpack there. So we are going to be doing a webinar on November 15th. That's a Tuesday at 12 o'clock Eastern. You can register for the webinar on our website, shpllc.com/webinars. There's a link to register right there. It'll be with me, yours truly, your local friendly data geek and QPP nerd. We'd love to have you, and we'll unpack that as a group. But Jason, is there an interview today? Who is it?
Yeah, we've got Joe Ebberwein, co-founder and CFO for Corstrata, who's going to talk about the wound and ostomy care market and what Corstrata is trying to do to help solve some of the problems there. So really interesting comments, insightful education by Joe. Looking forward to it.
All righty. Looking forward to it. We'll see you all later.
Hey everyone, I'm Jason Crosby with Strategic Healthcare Partners and your host for Beyond the Stethoscope, Vital Conversations with SHP. Today we are joined by Joe Ebberwein, who is co-founder and CFO for Corstrata, a tech-enabled solution provider for the wound and ostomy care markets. Joe, thanks for joining us today and welcome to the podcast.
Yeah, great to be with you today.
Look forward to it. Well, we've got some questions lined up for you, but first let's start with just some background information on yourself and kind of your journey in the healthcare industry.
Absolutely. Yeah, so my background's actually accounting and finance, got an undergraduate in accounting, and then did the CPA route and worked for both, and this will age me, but both Arthur Andersen and Price Waterhouse, and started working in healthcare early in that career, doing CPA work, auditing. Was in Atlanta for a little while and then moved back to Savannah and actually began work with Memorial Medical Center, now part of HCA. but worked primarily on the post-acute side, and the for-profit entities, which back then were the air ambulance and MedStar, the ground ambulance, and then all of the other ancillary in-home services, such as home health, DME, etc. So I've really spent most of my career in that space, just about anything that could be done in the home, from nursing, traditional home health, hospice, private duty care. And then as the years went on, back in the early 2000s, the agency that I was involved with, we got into telehealth in a big way and the use of vital signs monitoring in the home. So we were one of the early adopters really nationally, and kind of became known as national thought leaders around implementing that use of technology in the home health space. And we saw some pretty amazing results. We saw improvement in clinical outcomes and improvement in financial outcomes. So we were much more equipped to manage patients with chronic conditions like CHF, COPD, etc., in the home using this equipment. Again, back in the early 2000s, clunky, expensive equipment, but fast forward, that was really kind of the initial groundwork for what my business partner, Kathy Pate, and I ended up doing at Corstrata about 7 years ago. And really what we did is we took that concept of how can you apply technology to a healthcare problem. And we had experienced a big problem in managing chronic wounds for patients that were in home health. So similar to the teleradiology model, we thought, kind of came up with a thesis that we could move images similar to radiographic images to a distributed workforce. And that workforce happened to be board certified wound and ostomy nurses. So we started doing a lot of R&D into research around how could we come up with a technology solution to that problem. So that's really kind of how Corstrata was born 7 years ago. But that's my background. Finance, accounting, but a whole lot of other hats along the way in early stage companies.
Yeah, it sounds like a natural evolution from the early 2000s. You got to see telehealth early on and home health, and now that's kind of all you're hearing about, right? So kind of makes sense now that you mentioned with Corstrata. So let's dive into that. You've touched on it. Tell us a little bit more about the operations of Corstrata, the problems you're trying to solve, who you're trying to solve them for, right? Who's your typical client? What type of provider setting? Dive into that a little bit for us.
Sure. Yeah. Wounds are an interesting problem because no one really owns wound outcomes. You've got cardiologists that are dealing with cardiovascular issues, or endocrinologists dealing with kidney and diabetes function and that kind of thing. But nobody really owns wounds because they cross multiple comorbidities. You might have wounds related to vascular issues, lower extremity wounds, a huge prevalence of diabetic foot ulcers in the diabetes population. 1 in 4 diabetics will get a diabetic foot ulcer in their lifetime, and 1 in 4 of those will have an amputation. And then the 5-year mortality rates are off the chart crazy for people that recover from an amputation. So those are the kind of wounds. Additionally, you have a multitude of other wounds related to different conditions, whether it be pressure injuries from immobility, or, a lot of times you hear them referred to as bed sores. And unfortunately, that's highly prevalent in skilled nursing facilities. And a lot of them can be prevented with the right education, with the right techniques, the right surfaces, etc. So it's a $96 billion problem. 15% of all Medicare patients, members, have a wound. And the real problem that we're trying to solve and chipping away at it is that there are only 15,000 board certified wound nurses in the country. And that equates to about 1 nurse for every 600 patients. It's not sustainable. The number of diabetics, obviously we know that that's growing. We've got about 37 million diabetics and another 96 million pre-diabetics. So it's a really, it's like a freight train going down the track, and it doesn't have a good ending. There's a big wall at the end of it, and it's all around access to these specialists. So as I said, no one owns wounds across multiple specialties, multiple provider settings, whether it's home health, skilled nursing facilities where about 1/3 of the patients have a wound, LTAC, rural hospitals. All of these different care settings have patients that present with wounds, and yet we don't have the expertise to really manage them and get evidence-based care. 1 out of 10 nurses that are certified in wound and ostomy care practice in the post-acute space. So, and that includes home health, hospice, SNFs, rural hospitals. 90% are practicing in the hospital settings and outpatient wound centers. So, I mean, you can see there's such a disparity with where the experts are. We're solving that problem with technology in a number of different ways, and I can go into that if you want. Or
yeah. So with that, the key obviously being technology adoption,
right
on the provider side, and some are a little bit more accustomed to that adoption, some aren't. With that, and with the gap in qualified nurse on the outpatient side, as you just mentioned, are you seeing those as your key barriers, or what other barriers are you seeing to entry into those spaces?
There are a number of barriers. One of them that's really interesting is some providers don't want to take wound images of their patients' wounds. And you can kind of see that, right? Because of litigation, discoverable in the chart, etc. But what's interesting is most of those patients, say with a pressure injury or pressure ulcer, if it gets bad enough, somebody is probably photographing that wound. And what we try to get across to our clients is, do you want, a qualified professional taking photographs of the wound over time to show the progression and have the medical records support that decline or hopefully improvement? Or do you want, the patient's nephew to have the photograph in a court of law? So a lot of times we can get over that barrier pretty quickly. The other barrier is we're really a value add to our customers. So whether it's home health or hospice or skilled nursing facilities, because we are a nursing model, we're not billing any Part B, we're not billing any commercial Medicaid. We bill our clients, and our clients get a return on investment from having access to experts. So we can reduce, nursing time, home health visits, we can reduce those. We can reduce their spend on advanced wound dressings, and also, really, to be honest, help them with coding and reimbursement as well, because a lot of times they're misidentifying wounds and they're leaving precious dollars on the table from a reimbursement standpoint.
Sure. And it sounds like if 15% of the Medicare population have wounds, and there's obviously a growing number there, right, I would just imagine there's greater demand for that type of service. Where are you starting to see some of those trends, knowing that you've got the aging population, you've got hospital closures, not only rural hospitals, but you've got WellStar, for goodness sake,
in Atlanta,
at the large hospital in Ohio, and that's only going to continue, right? So go down that path a little bit. Do you envision continued demand for such a service, or is that just going to become a barrier for you as well?
I think it's going to become quite an opportunity for further penetration in multiple markets. And I'll tell you just a couple of examples. We're working with some large hospital systems on the West Coast. And these are big hospital systems in urban settings. And because of lack of staffing, they're closing their ostomy clinics. So literally, we're getting that business through our virtual consultations we are able to do a 30-minute live video with the patient in their home, troubleshoot the appliance, save a ER visit, and assist these hospital systems that are desperate for staffing of these nurses. On Indeed.com, I went on there today, there are 4,001 open wound nurse positions across the U.S. Well, if there are only 15,000 certified, period, you can see there's such a disparity. And with COVID, kind of the great resignation, a large number of nurses who are considering leaving the profession, it's a big and growing problem. So hospital systems, as you mentioned, rural facilities, really just about anybody that in the post-acute space also that is dealing with a wound.
What do you say to those then? There's obviously the appetite, the demand for the service that you guys are providing. Many reasons, as you just laid out, there's still slow adoption to that, whether you're a skilled nursing facility, rural hospital provider, large health system, practice setting. Across the board, there's not a provider that can't utilize the service. What do you tell those that are just hesitant to look in that direction and start investigating, a service like yours? What do you say to them to get them across the line?
Great question. And I do think that COVID and the adoption of telehealth broke down a lot of those barriers for us, because a lot of facilities had to move to virtual care. They had to, put the systems in place, not only from a technology standpoint, but also all the infrastructure. And so that has actually helped us in telling that story. But, for instance, when we talk to, say, rural hospitals that now are either not able to admit a wound patient or they're having to transport them to a higher acuity system because of lack of expertise, it becomes really an amazing impetus to start considering using virtual care.
So the market's almost telling them itself, hey, this is why you need to look into it. They don't necessarily need the sales pitch. I mean, just listen to the market and let the market tell you need to look into something. No, that makes sense. Let's pivot somewhat into that. To me, that virtual health, telehealth is kind of a disruptor that we need. So continue looking at that, and let's also look into your crystal ball, right? What are some innovations that you're seeing in these service areas that, what are you seeing coming down the horizon there?
Yes. So interestingly, we have, and this is one example, but we have a diabetic foot ulcer prevention program. So, obviously diabetic foot ulcers don't just occur in the Medicare population. These are people that are working, their 40s, 50s, some even younger, that have severe diabetes, they develop neuropathy, and they end up with a diabetic foot ulcer. And, it's just an incredible kind of cycle. It can spiral down. Well, we have working with companies that have electronic sensors for measuring temperature and pressure in the insoles of shoes. A lot of technology is moving toward prevention, and most diabetic foot ulcers are preventable if you have the right early detection. So that's one example. There are sensors built into orthotics for measuring compliance. And what ends up happening is that data, that sensor data that tells that someone's getting into trouble, that comes to an entity like Corstrata, and then we're able to intervene. We had a really interesting, this is just an anecdotal story, but we had an interesting encounter with a gentleman who was using one of these monitoring systems, and every weekend he would alert. And so we knew something was going on the weekend where he was getting elevated temperatures, which is a precursor to ulceration. And so one of our nurses said, okay, let's dig into this. Let's do a video call. I want you to show me every shoe you have. I want you to tell me what you're doing on the weekend. Well, turns out he had a part-time job at a funeral home, and he had to wear a certain kind of black shoe, and it was not the proper shoe to relieve that pressure. So we got him in the right shoe. The alert stopped coming in. But that's the illustration of, you got all this great sensor data, but what do you do with it? And then that human intervention, that biofeedback, and coming up with a plan to really prevent that ulceration.
Wow, that's a great applicable story that anybody listening can certainly resonate with, right? I mean, that's great. Appreciate you saying that. What's now on the strategic roadmap for Corstrata? What are you guys working on today and over these next couple of years?
Yeah, so it's been interesting over this last year where we had predominantly really been working mostly in the post-acute space, like home health, hospice, skilled nursing facilities. What we're starting to see are some of the emerging models for really acute care services in the home, hospital at home, if you will. And we're working with a number of those organizations that really help facilitate a hospital building a hospital at home program. Where that becomes really interesting is, and this was really accentuated during the pandemic, you've got these acute patients who really, when there weren't enough beds in the hospital, could be managed in the home with the right equipment. And when I say hospital at home, I'm talking there is hospital grade equipment, hospital bed, vital signs monitoring, all going back to kind of a Star Trek central station, constantly monitored, daily nursing visits, nurse practitioner visits, etc. So, imagine that they're really setting up a command center in the home that is, transmitting data. So hospital at home is an emerging market, and a lot of those patients have wounds and ostomies, and so they're engaging with us to do virtual consults for the people that maybe do not have experience with wounds. Other innovative type things that we're seeing are mobile physician groups that are doing primary care. Obviously, the proliferation of ACOs and the whole value-based care bundles. We are in discussions with some payers that also have mobile clinical teams. So yeah, it's really kind of been an interesting year, and it's a shift in who's approaching us for those kind of consults. Ostomy is a big deal as well. Even though it's not a big number like the wound population, it's a really high 30-day readmission rate into the hospital. And so ostomies kind of go hand in hand with wounds because of the certification of our nurses.
Interesting that, here you just talked about 20 years ago, the focus was all on the skilled nursing facility, if that. And now
Right.
You can span across any provider setting, ACOs, practice setting, it doesn't matter. Come a long ways in just the last 20 years. So another exciting few years ahead, I'm sure.
We're seeing such incredible stories, both with individuals living with ostomies that literally were driving to an ostomy clinic 4 hours away that can now do this in the privacy of their home, to people with long-term chronic wounds that just never had the right evidence-based treatment plan, and we're getting those wounds closed. Obviously, saving a lot of money for the providers, but the human impact is amazing as well.
Finally, Joe, if our audience wants to learn more, how do they go about doing so?
Sure. So lots of ways to contact us. Obviously, our website, Corstrata.com. We're on LinkedIn and Twitter and Facebook and just about any social media. So very easy to get us.
Well, some great information and even better conversation, Joe. Lots of data to support. What you guys are doing is a great thing. It's a service that's needed out there in the marketplace. So really appreciate that. And I'm sure the listeners will find it just as useful as I did. You definitely opened my eyes to a lot of things there. I appreciate that. And we really appreciate your time and joining us today. I want to thank our listeners, too, for your time. We look forward to our next podcast. And until then, everybody have a great rest of your day.
Thanks for having me.
You've been listening to Beyond the Stethoscope, Vital Conversations with SHP. This has been a production of Strategic Healthcare Partners. Your news hosts today were Jason Crosby and me, Aaron Higgins. It is produced and edited by Nyla Wiebe. Our social media content producers are Nyla Wiebe and Jeremy Miller. And our executive producers are Mike Scribner and John Crew. For more information about SHP and the services we offer, including the back library of episodes, episode transcripts, links to resources discussed, and much, much more, please visit our website at shpllc.com. Thanks for listening. You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.